I want to welcome you all to September's BayCare Present. I'm very excited to have Dr. Claude Lewis back again. He was here early in the year talking about lung cancer and lung care, and he's going to be talking about the heart today, which is such an important topic because as an exercise physiologist, clinical health coach, I love the prevention of heart disease, doing all those modifiable risk factors that we can impact, but heart disease still remains the leading cause of mortality worldwide. Early detection is very important. And when you get to the point where you do need to have intervention, you definitely want a world-class surgeon at your side like Dr. Claude. So I am going to turn it on over to you, Dr. Lewis, and let you share your great information.
All right, well, thank you so much for having me. This is an interesting talk and something that I value very much. So, needless to say, I'm a little biased. Um, I'll go to the next slide. All right, so again, I'm Claude Lewis. I am born and raised in Miami. Did some training in Washington, D.C., Rochester, and Boston, Massachusetts. But I'm back here in the state that I was born in, and I'm excited to be here at Winter Haven Hospital. The topic I'll be discussing is on heart disease, so beyond the basics, so prevention, diagnosis, and treatment. So coronary artery disease is essentially when you have blockages of the vessels that feeds the heart muscle or the myocardium. These coronary arteries become narrowed, and you have a decreased blood supply going to these important areas. There's some important words that needs to be defined as it pertains to heart disease, and that's ischemia, which means that you are not getting enough oxygen from the blood supply to the heart, so the heart is kind of struggling a little bit. And then some of the symptoms that you may get would be like angina, which is chest pain, a specific chest pain, which the origin is from the heart because it's not reaching its supply. And then subsequently to that is a heart attack. That's like a bank account overdrafting. The amount of blood supply that is required for the heart is not sufficient, and the heart could never take a break. So you essentially have an overdraft on that transaction. And that's when you have a complete blockage or, again, a deficit of blood flow that leads to some damage. And you can see the contents of that damage in the blood supply with some of the cardiac enzymes. And I'll speak more of that, and one of which is called the troponin. So there are a multitude of medical treatments. We don't just jump to the biggest, but there's a couple of things that you want to do for patients who do have coronary artery disease. What are some of those things? Well, aspirin is a medication that thins the blood. A beta blocker is a medication that prevents the heart from working too hard and too strong. For instance, the squeeze ability of that pump may not necessarily need to be as strong as it needs to be. You can decrease the amount of energy that is required by working on that pump and the speed in which it's pumping frequently. So the heart rate, a beta blocker will help decrease that. Statins will lower the cholesterol. And one of the blood pressure medication that does a very good job in these patients are the ACE inhibitor medications. Um, Subsequent to that, some other opportunities that may help have some adjuncts in helping is diuretics, which is a water pill. Other blood pressure medications exist as well, and other antiplatelet therapies. When you do have an event where there's a substantial blockage, and those numbers depends on which vessels, could be 50% if it's what's called the left main, or 70% of any of the other blood vessels throughout, then now you're talking about a patient who has symptoms and has a finding of a blockage. So then now you go down the pathway of should this patient get a stent, which is like putting up a gate or scaffold that forces the vessel open, or subsequent to that, a bypass. And those decisions are important to make carefully because you're forever changing the patient. There are a multitude of risk factors that participates as to why patients come down to having severe coronary artery disease, some of which are things that we can modify and some of which are things that we cannot modify. Modifiable risk factors as seen on the screen could be diabetes, obesity, could be physical inactivity, the misuse of alcohol, and more importantly, things like smoking and high cholesterol. But what are some of the things that we can't change? Well, our genetic predisposition and family history, our race and ethnicity. Some races may have a propensity for higher chances of having coronary artery disease, as well as sex and aging. Although I may be biased, heart disease actually is very important as it pertains to leading cause of death. As in this slide, and has been so for a multitude of years, heart disease, coronary artery disease, is the number one cause of dying in United States. And even if you were to look at the pandemic of COVID, we have the numbers here. And second to that would be cancer, which is a multitude of diagnosis. But again, heart disease is that number one cause. You control heart disease, you can control a large volume of patients who are dying in America. But more than just that, what's happening in the world? And we're seeing that there's a multitude in the millions of heart disease, also ischemic heart disease as a formal definition, being a leading cause again. And now we're talking about throughout the world, outside of America. This is a problem as seen by the World Health Organization. The top 15 leading causes of death in the United States, again, we see where heart disease ranks. So all of these graphs are essentially saying that this disease is really, really important, and the Center of Disease Control has identified it as a number one cause of death. And knowing that there's a multitude of modifiable risk factors, it is important that we try to control this problem. If we were to separate along sex, what would be the number one cause? As you can see, it is still in both the number one cause of dying in both males and females, knowing that it's a little bit higher in males than is in females. And these numbers here are age adjusted death rates per 100,000 individuals. But still, the consensus is heart disease leads among all of these things. But there's a number of diagnostic modalities that we should become familiar with, or things that will come to our office here in Winter Haven so that we can kind of characterize where you are and better understand your disease pathology. An echocardiogram specifically is kind of a sonogram of the heart, and it tells us how the valves are behaving because we can now see inside the heart, and as well as the muscle walls are contracting. It gives us a great perspective of those things, specifically the muscle walls contracting because they are fed by blood vessels. So we can see the downstream effects if you were to come in and have this particular procedure, which is non-invasive. It's going through the skin and looking through you, and essentially will tell us how well the muscles are squeezing, and that depends on a blood flow. And we can tell different areas are down, which may correlate with different blood vessels. There's CT angiogram, not frequently used, but is a CAT scan that can give the anatomy overall of the patients who have heart disease or any other structural related changes of their heart. So just to be familiar, this is a CAT scan, but since it's involving some of the vessels of the heart and giving you a perfect picture, this is more specifically a CT angiogram. But what is the most important method in which we diagnose heart disease, specifically blood vessel problems of the heart? And that is a coronary angiogram, also known as a cardiac catheter, also known as left heart cath. It goes by a multitude of names. This is diagnosed by a cardiologist, and the cardiologist, a specifically trained cardiologist, interventional cardiologist, who will find the lesions. And how do they do so? This patient essentially is in a cath lab, and there is a IV that is hooked up into the patient's arterial system, and they take that catheter and insert it right above the heart where the openings for the coronary arteries are, and they squeeze contrast. So in this picture you can see the dark illumination. That is the inside of the blood vessels, and you can then characterize the specific areas of narrowing of the heart vessels. And then at that point, decisions are made as to whether a patient will go down the pathway of potential stenting or a interval heart surgery at a later time. So it's important for us to have some conception of the anatomy, so to speak. The heart is typically, in most patients, unless you have what's called situs inversus, on the left side of the chest and slightly rotated leftwards. There are two major arteries, typically, a right coronary artery, which is usually smaller than a more robust left coronary artery, which feeds majority of the heart, the left one. And as the left comes out, we call it a left main. And when it starts to go into different blood vessels and branches of it, we call it a bifurcation that leads to two other names, left anterior descending and left circumflex. The left anterior descending had a previous name. We don't use that much anymore. They used to call that the widowmaker. We call that the LAD, the left anterior descending. So if we were to take away the actual muscle and look at some of the blood flows here, you can see the specific blood vessels here. And that's the right coronary artery, which mostly stays as one with some branches. And then you have the left coronary artery that is mostly a main, and then it either splits into two or three main vessels, one of which is called the left circumflex, and the other one is called the left anterior descending. So when you hear about a triple bypass, typically these are the three that they're referring to, sometimes branches coming off of them. Again, left circumflex, LAD, and right coronary artery. So you have a patient, and they're not a patient at first. This gentleman is not wearing a gown. Could be at church, could be walking dog, is having an excruciating chest discomfort. Comes to the hospital and an EKG, an electrocardiogram, is performed, and they may or may not see some changes. And then they order a blood test. And this blood test is looking for a specific cardiac enzyme, which kind of hints as to the possible etiology or reason for having this chest pain, because this enzyme is typically found on the heart and not free flowing in the blood. When it's free flowing in the blood, it's telling us that there is evidence of a heart attack, which means heart death and some level of damage and spilling into the blood system. And thus, in that situation, a patient who has a concerning EKG has evidence of spilling troponins in the blood, the indication to go to the cath lab to have an interventional cardiologist diagnose as to the specific blockages or blockage, just one, of any vessels that's involved. So that's how you diagnose in the cath lab. What are they specifically looking at? Well, this is kind of the pathophysiology here. You have an area that's downstream, so further down the blockage, because they are going to be getting the lower blood supply. All the other exits of that highway are free flowing except for that very far distance. Those areas of muscles will struggle because of the early blockages. And you may have what's called ischemia, which means an active decrease in blood flow going to a territory, or an infarction, which means a heart attack. There was a damage that took place. There was an overdraft because there was a deficit or inappropriately low amount of blood flow going to a territory. Why would that happen? Atheroma, atherosclerosis, which means essentially cholesterol and cholesterol plaques. So what are some of the algorithms in which they're treating these same patients? Come in with chest pain, EKG. Blood work, you're looking for troponin. If the EKG says you have a specific change, which they say is an ST elevation, we call that a STEMI. If there's not a specific change of the ST, which is long story short, but as seen on the bottom left of that picture there, is a specific area on the EKG, but the troponins are spilling, then you'll call that an N-STEMI. That means there is no ST elevations. And then if you have no blood spilling troponin and you don't have the ST changes, then you call that an unstable angina. But all in all, all of them are some form of acute coronary syndrome. We just have kind of levels to this, of which the STEMI is the worst one, because that finding means that there was a complete blockage, either currently happening at the time of that EKG versus a partial blockage in an STEMI versus having just an inappropriately low amount of blood flow going to different territories, and thus you have pain with unstable angina. So the first step is you're in the cath lab, you either diagnose it, and if it's the correct patient, perhaps a patient who just needs one stent, then you would stent at the same time. But when are we going to heart surgery and when is that appropriate? Well, you diagnose it, and I'll give you an example. That patient is found to have multiple blood vessel blockages. Perhaps one may be the culprit that's leading the pack, but you have 3, 4 different territories of blood vessels having 70% narrowings. Then now you're talking about longevity on that patient. How do you get that patient back to their normal life curve and life expectancy? How do you resolve all of those issues so it's kind of a one and done procedure so that they can not have to deal with this in the future or have multiple reinterventions, multiple stents down the way? That is a patient who is more appropriate for a bypass procedure, also known as coronary artery bypass graft. And I'll later on go through some of what the literature says about that. But technically speaking, patients who have multiple areas of narrowing or a complex territory that a stent would have a tough time doing a good job. And I'll give you a quick example of what that looks like. If the area of narrowing is right before the vessels need to split to feed two territories, that means it's proximal to a bifurcation, then it might be complex for stenting to do a great job. Not impossible, but complex. And having to re-intervene on that within 1 or 2 years or 3 years is certainly higher than undergoing bypass. So if they can tolerate a surgery, they should be considered. Just to speak on stenting a little bit, this is not a procedure that I technically do, but just to make sure I represent our interventional cardiology colleagues, you traverse the area of narrowing with a wire, you load a stent on that, which again is going to be something that you're going to deploy. You open it up with a balloon and it forces that stent to acquire this cylinder shape, and now it re-establishes the ostium or the opening of the blood vessel that has the narrowing, and it excludes that narrow blockage so that the blood vessel can then go back to having flow. And you would do that over the critical areas that has narrowing in that patient. What are the findings if you were to do this in a patient? So again, the coronary angiogram, also known as cardiac catheterization, also known as left heart cath, that the interventional cardiology is doing, they see this one area of blockage of the 3 vessels. We only see 2 on the screen because right now they're putting it in the left main to inject contrast. The right coronary artery is separate. But for all intents and purposes, this patient just has one narrowing and it's in one area. So you cross that narrowing with a wire, you load a stent on that, you deploy it, and then now you have the picture on the right. That vessel is now open and they're now fully treated. Cardiac surgery is a little bit different. You take a patient who equally has a narrowing, but they have, let's say, multiple areas of narrowing. So now we can create multiple highways to address that particular patient. Very rarely are we doing single bypasses, but sometimes it's necessary. But doubles, triples, and quadruples do exist. This is kind of a process as to how this would be done. We're typically using what's called the left internal mammary artery. This artery is a blood vessel that is incredibly important. For most patients, it's staying open for more than 25 years. It keeps us in business for sure. And it certainly does better than most stents. This blood vessel really establishes patients back on their life expectancy and their life curve. And then for the other blockages, we'll use a combination of perhaps the radial artery, which is an artery in the wrist. We acquire that with a camera here, or we're using the veins, which is in the leg. We no longer do the large incisions. We use a camera, very tiny incision, to acquire a length of vein, and we use that to reconstruct the remainder bypasses. So the LAD, which is that most important blood vessel that they used to call the widowmaker, we put the mammary artery on that, which is that long vessel there on the screen coming off of that large blood vessel above the subclavian. That's where it is. We just reattach the endpoint, and then we reestablish with the other bypasses a connection from the aorta to the area of blockage. So now you're going beyond the area of narrowing and you're establishing a new highway after the traffic jam. We don't touch the previous blockage. You can still use it. Perhaps if you have a 70% blockage, then 30% of that area is still open for blood flow. So now you have two ways. You have the bypass we created and the system you were born with that is narrowed to now feed the different territories on your heart. This is how the procedure looks like for us. We establish a sternotomy, which means we go through the sternum right at the level of the notch to the pointy tip down the middle above the actual abdomen. We make an incision on the skin, an incision on the bone. We put in a sternal spreader, and now we can see the heart. We acquire the mammary artery, which I told you is the most important blood vessel that stays open for most patients, sometimes greater than 25, 30 plus years with very little intervention. And then we get the other bypass grafts that's coming from either the wrist with one camera or in the leg with another camera at the same time we start the procedure. We give the heart a medication to go to sleep, and you can see it's in that catheter there with the red lining. So that puts the heart to sleep, and we have 45 minutes to an hour and a half of work to do while the heart is sleeping. Probably closer to 45 minutes. We establish all the bypasses and resurrect the heart right back. And the heart is then happy after the bypass procedure. So what does the literature say about these patients that we are doing these procedures on? Well, here are 5-year outcomes after PCI, which means stenting, or CABG, for a patient who has a narrowing in the most important area of the heart, the left main. That means the entire left side vessels are experiencing a decrease of blood flow. So in those patients, which is diagnosed as a 50% narrowing in the left main before it splits to the left anterior descending and the left circumflex, we can see an A, death, stroke, or myocardial infarction, which means heart attack. The CABG procedure after 60 months has a lower incidence of these things, whereas stenting has a higher incidence. Now, I look at CABG, or coronary bypass graft, as an investment procedure. You take on more risk up front, but you plan on living longer than the 1 month or 2 months in which that risk was relevant for, but you want to be around for 5 years, 10 years, 15 years. This is where the curves start to change. And on this graph, you can see somewhere around before 36 months, there's an inflection point where clearly the investment of doing a bypass procedure for those patients may have been the right answer because their risk is lower. In column B, looking at death, stroke, heart attack, myocardial infarction, or having to repeat procedures, which is ischemia-driven revascularization, you have in CABG, this incidence is much less after 60 months, with it being much higher after 60 months with stenting, specifically involving the left main. Now, if we do a deeper dive, of course, this literature is based on more than just 2 slides. You'll have in there the different type of stents, because those are evolving, and the technical skills of surgeons are also evolving. So it's always a moving process. But all in all, these are the findings at just 60 months. So imagine what 120 months looks like, which would be 10 years later. If you talk about the other areas of the heart vessels, not the left main, but the actual downstream vessels, which their indication for revascularization is about 70%. So let's say you have a patient who has multi-vessel disease involving the left circumflex at 70%, the left anterior descending on this slide is the anterior interventricular artery at 70%, and the right coronary artery at 70%. What does the literature say for doing bypass versus stenting? And in both these graphs, if you look at the first one, for instance, what is the event-free survival? That means you're surviving, you're not having another event of these poor outcomes. And what are those poor outcomes? Death, stroke, having heart attack, or having to repeat revascularization. I want to be on that upper curve. The more dark line represents bypass surgery, and the dashed line represents stenting. And you'll notice that it's much lower event-free survivals. Go down the stenting pathway, you may have to see a cardiologist again and again. You may have another heart attack. One stent may go down, you missed the medication, that keeps it open for 1 year, it could be a problem. There's a number of things that tells you that for multi-vessel, coronary artery bypass graft should be considered. And the same is also seen in D, which represents freedom from revascularization. And as you can see, one person is having maybe a C minus, and the other one is probably above 95%, which is an A back in my school days. So just all in all, just to recap, when we look at PCI stenting versus CABG, what is the right pathway? When are we moving forward? Is it less invasive for PCI stenting? Absolutely. When is it best? Fewer blockages. What is the goal? Relieving symptoms, improving quality of life. What are the opportunities that exist with doing stenting? Well, you have a shorter recovery time, usually 1 or 2 days in the hospital, sometimes less. And then you do have the higher rates of repeat revascularization and stents over time. Whereas with bypass, it is more invasive. It's an upfront investment procedure. It's better for complex blockages or multiple areas of narrowing. It has excellent long-term outcomes, but there is a longer recovery time. It could be a hospital stay as much as 5 to 7. The hospital food is not the greatest nowadays, except for New Haven Hospital. And lower rates of repeat revascularization, and almost never, very infrequent, having to ever have heart surgery again in the future. So as you think about the next steps and how do we keep ourselves safe, so we avoid all these pathways, cholesterol testing, blood pressure control, age-specific lipid panels that tells you what your numbers look like that a primary care physician would be helping you to assess, making sure you're staying active and improving the body overall. BMI for some don't find it as accurate, revealing the true story, and making sure you diagnose diabetes should you have it, because diabetes is a very big risk factor for coronary artery disease. Many thanks. That concludes my small conversation on coronary artery disease. You now know why I love this field and this pathology in particular. We are a 3-star STS level hospital as it pertains to revascularization, which is the highest of the levels. Very few hospitals are able to acquire those outcomes for this procedure. It's the most common procedure we do as heart surgeons overall, and in this hospital as well. Happy to take any questions. Thank you so much.
Thank you so much. It is just such a interesting topic. I personally, I think like most people in the audience right now, have had someone in their life touched by some sort of heart disease. My father had his first heart attack at 48, which he then had to go in for coronary bypass. And I gave him 20 years of quality life after that. So I think it's just incredible what's able to be done. But I love how you present, because you can definitely see your passion as well as your knowledge. And I love some of your visualizations about the overdraft from the bank and, the gates, so you had great imaging. I think that helped us to understand very well. When you were looking at the CT scan, is that similar to the calcium score test?
A little bit. The calcium score specifically It will just tell you if there's calcifications, and not all blockages represent as calcifications. Calcifications are more of a chronic change, shows up a little bit later. But what if you had a blood clot that somehow was involving the blood vessel? That would cause a decreased blood flow to a territory without showing the calcifications. So we look at calcifications, that would be more of a screening. You look at that, if you see something, go after it, but it doesn't always tell the whole story. So it may not be specific, but it is sensitive.
Very good. I'm going to read some of the questions to you, but if you can go to your top of your screen where it has the little X that says stop sharing and stop sharing. We're seeing two screens. Perfect. All right. Well, we had some questions, and one was when you were talking about nitrates or nitroglycerin or the medications. Nitrates were thought of as being bad for us. How is this different than the food additives to the medication?
Food additives to medications. Well, there's a reason for every type of medication, and I would say more than just nitrates. There's that whole chemical method. There's nitroprusside, for instance, which helps with blood pressure, which I would not say is bad. And some patients don't respond to one type of medication. Some patients need multiple medications to keep their blood pressure in check. As it pertains to nitroglycerin, which is going to be very different, that's really helpful for the patient who has ongoing chest pain to relieve their symptoms at the time, which may help a little bit, but ultimately is reminding you that more may need to be done, which I also would think is not an unreasonable medication to have safely when prescribed by a physician who's monitoring the patient for heart disease. As it pertains to food additives, this could probably be a little bit longer of a scope, to discuss. There are a lot of things that are in our food. That certainly can be one. But I would honestly think more so sodium, not even going as deep as this, some of the food additives, period. Just sodium, salt, table salt. That's something that's getting us into a lot of issues. Eating high cholesterol meals, I would think more importantly than some of the additives and the rare names that are showing up in some of the meals. So I would think there are some easier changes that can be made as opposed to changing some of the more narrow scope changes of what are some different organizations adding to food that may be causing these things. I would say if you're looking at your salt intake, if you're looking at your cholesterol, meals, and if you're appropriate for a statin, a cholesterol lowering medication, be on that. Some people have complications with it, such as muscle pain, but those who don't, finding the right regimen to decrease their cholesterol would be the major focuses I would rather share than some of the more rare things.
Can you give an example of what an ACE inhibitor medication is?
Yes, so an ACE inhibitor is the word ACE stands for angiotensin converting enzyme. It happens to be a product that's made in one area, involves the kidney, involves the lung. These are very complex methods, but that chemical, so to speak, when you use an angiotensin converting enzyme inhibitor, you're preventing that chemical from running around the body and causing an increase in your blood pressure. You're decreasing that natural process that's behaving naturally and causing blood pressure increase. More than just how it works, it's what has it been doing as it has been working. It has been shown to decrease mortality in patients, so decreasing death for patients who are in the spectrum of having coronary artery disease. That medication, for the most part, ends in the word pril. So you may have heard of lisinopril, which I'll probably say is probably its most popular, but there's ramipril, enalapril, there's all types of prils. Some patients have an allergy to that. One could be what's called an ACE inhibitor cough, unfortunately. Really bit of a nuisance. There's a cousin to that medication that we would consider using in that case or in other cases called the angiotensin receptor blocker, and that is an ARB medication. But so to speak, it's about what has been shown to benefit patients outcome wise, not just how it actually works, but what has it been doing out there in the cohorts of patients who have been taking it. And it's one of the medications that has been really, really helpful for patients who have heart disease. Beta blockers as well. Just want to just quickly mention that. And those are the medication that ends in OLOL. They are decreasing kind of the overdrive working of the heart unnecessarily. You don't necessarily need to have your heart beating 99 beats a minute when you're at rest watching, a movie, for instance. You're having all that extra work, and therefore you need to generate all that extra blood flow, and you're trying to do it, forcing the muscles to still require more and more and more. So it's kind of like when you're running, and you get that sharp pain, but you can stop and rest. The heart can't. So if you can decrease that overdrive of extra beats that are unnecessary and the extra squeeze, that has also been shown to help, as well as the
Excellent.
aspirin.
The next question we have is, how do you know when revascularization is required, especially if there's no real ongoing symptoms of any other heart issues?
Yeah, it can get complex, but I would say revascularization is for the patient that has signs of ischemia. So you have a decreased amount of blood flow going to a territory and objective evidence of the narrowing. So not only do you have the sign, but you have the objective assessment, for instance, the coronary angiogram. So if you were a patient that said, all right, I'm not having any pain at all. But then I ask you, you know, what have you been doing all week? Oh, I've been, sitting in a chair. Okay, so maybe you have stable angina. You then go out for a walk farther than you typically go. You climb the stairs. You're having this crazy chest pain. Your lifestyle is that you potentially have changed it, so you're not getting these symptoms. So then, all right, it sounds like it may be heart related. We're not sure. You do a stress test and you stress the heart. You don't just jump to a coronary angiogram or a cath, but you do a stress test, and that helps us define what direction you should go. You stress the heart, and it starts showing the EKG changes. The squeeze is not no longer good. It can't make that effort to get there. Now we know something is going on. And then the next step potentially would be to do a coronary angiogram. And that could be a setting where someone who typically didn't have much symptoms, but come to find out really did. And then you're finding that they have disease. Because what you realize is some patients have had coronary artery disease their whole life, their whole adulthood. And it doesn't reveal itself until it's tried its best to help. You're talking about 90% blockages in multiple areas, collateral vessels. That means the vessels were struggling so bad, it created new vessels to connect them that you were not born with. The heart is doing that in many cases. So they're not typically presenting with symptoms because they've done a great job masking what's really happening underneath. They would need a revascularization. And again, based on the criteria, is it numerous? Is it few? Is it focal, so short narrowing, or long narrowing? Is it before the vessel splits into major arteries? All those things would say which pathway you should go. But someone who has an acute problem, has an objective diagnosis of a blockage, they would meet criteria.
All right. I am going to drop next month's talk. And again, I just want to put a reminder out there that we did change the platform, so it will look different from how you registered before. But we have two more questions for you, Dr. Lewis.
Yeah.
So one is, do you have any idea for places that people can go to get more information, where they can go research different ideas about the heart, particularly our older adults, that is going to give them the great information that you shared with us, that they can't call you and talk to you constantly every day? And then I cut you off when you were going to talk about aspirin, so I'll let you bring that back in to close us out.
Yeah. Perhaps I'll start with the aspirin first, and the other one sounds like a better closure. Um, so the aspirin has been really helpful in antiplatelet therapy. Now, there's been some research saying, is it necessary? You then have to go to the risk profile, of certain patients, because certainly when you give someone aspirin, could they have a small chance of bleeding? But all in all, you're decreasing the chances of forming these inappropriate clots that platelets are participating in and potentially causing harm. You're thinning the blood to some extent. And again, we're talking about just a baby aspirin, so this is not even the 325 milligrams, it's an 81 milligram aspirin. That, as well as angiotensin converting enzyme inhibitors, the ACE inhibitors, as well as the beta blockers, they have been working together and doing a great job decreasing the events of patients. So if you were to say, I'm someone that has heart disease, right? You go down this pathway and you're found to have a mild moderate blockage, which unfortunately maybe many of us listening to this conversation right now, you don't have severe blockage, you have mild moderate blockage. Well, how do you decrease its propensity to cause harm in the future? Cholesterol lowering medication, perhaps an aspirin medication that's going to deal with the platelets and their adhesions and adherence, perhaps the ACE inhibitor we talked about earlier, and the beta blocker, more importantly. All of it is kind of working together. So I would say it's one leg of a whole large system in which there's other leg, arms, head, neck that participates in decreasing the instances of harm due to a coronary artery event. Now, as it pertains to where can you find more information, the first thing I would say is your local cardiologist, right? Now, not everybody is applicable or necessary to have a cardiologist, so perhaps we start with just a primary care physician who is doing annual labs or at the frequency in which is appropriate for checking the lipid panels, for checking your blood pressure, and you being truthful of symptoms you may have. It may be as simple as, you know what, I've been having blurry vision. Okay, let's go deeper. What is that all about? And then come to find out you have some risk of stroke or risk of cholesterol plaque and other things. Or I've been a little bit dizzy. Okay, let's think about that a little bit more. And then come to find out on the workup, very thorough primary care physician, you have a sound in your carotid artery known as a bruit, which has some plaquing, cholesterol plaque buildup there, which is the exact same disease process that happens on the heart. So when you work one up, you start working the other up, and you find out you have a blockage here and a blockage on the heart vessels themselves because the pathology is quite similar. So in the end, I would say the most important thing is to have great communication and compliance with the medications you should be on, seeing with your local doctor to make sure you're doing the best for yourself, and perhaps whenever possible, if you are someone that does have high blood pressure, monitoring it closely at home at whatever appropriate frequency of doing your own blood pressure checks. But I would start off with that because unfortunately, no matter how well you will research, what Mayo Clinic is putting out, Medscape, Chat GPT, you won't be able to test yourself. It's going to be more important to monitor your symptoms because your heart will try its best to save you and reveal when it's struggling.
Thank you so much. We appreciate your time, and we appreciate all of you being here, taking your time out to help with your own health and well-being. We hope to see you later in the year at one of our other events. And Dr. Lewis, always a pleasure.
Thank you so much for having me.
Have a great day, everyone.